Well, I know we're letting some people in and we're starting a few minutes late, but just everyone hold tight for a couple of minutes or maybe a minute. But rest assured, if you are here to learn about private sector delivery opportunities for the dual prevention pill, you're in the right place.
Mitchell, I think we can go ahead and get started. How does that sound?
That sounds awesome. Hello, everybody, and welcome. Good evening, good afternoon, good morning. I'm Mitchell Warren, the director of AVAC, and delighted to welcome all of you to this webinar, looking at what is really a critical moment and opportunity to think about the private sector and the opportunities we might have for the dual prevention pill. And I'm welcoming you not only on behalf of AVAC, but on behalf of many of the partners you see listed here on the screen who have been working together over the last couple of years in the dual pill consortium. And I know we've had different webinars, and many of you will have been on this call or these webinars before to get updates on the dual prevention pill. And we're going to take a deeper dive, particularly looking at some of the lessons from family planning for the future introduction of multi-purpose prevention technologies. I should say, although not shown on this slide, we are super excited to be doing this call today in partnership with FP 2030, a longtime partner with the Dual Pill Consortium and with AVAC to advance our common shared objectives related to providing people the products and services they want to need when they want to need them for all of their sexual and reproductive health needs. And so I'm delighted to welcome you on behalf of not just the Dual Pill Consortium, but also FP 2030. If we go to the next slide, I will very quickly go through the objectives for what we hope to do in the next 90 minutes or so. We are obviously here to talk about the dual pill, which would be the first new multi-purpose technology since male and female condoms. And we've done past webinars, and there's information on the website about the path to market for that product. And we're not going to get into the details in great detail on this call, because our focus here is to really look at some work that a number of partners have been doing, looking at private sector delivery models for the dual prevention pill. And we want to validate some of those recommendations with everybody on the line and share those widely. And we want to look at some of the best practices and potential barriers that the family planning field has had in engaging the private sector, because there's far more work over many decades of contraceptive delivery related to the private sector than in the HIV prevention world. So important that we surface some of those practices and barriers. And we really want to also work together with everybody on the line and those who might be listening to the recording afterwards to identify advocacy priorities and key stakeholders for how we might foster support for private sector delivery. So those are the objectives for the course of the call today. Next, I'll just quickly show the agenda. I'm here to welcome and do objectives. I'm going to go quickly. I'm then going to turn to my friend and colleague, Kate Siegel at AVAC, to give a quick overview of some of the questions and issues that came out of the April consultation that we did with FP 2030 to help frame this conversation. We'll then turn to colleagues at Halcyon and OFID who've worked with the Dual Prevention Pill Consortium, looking at opportunities for the private sector with findings from 3 countries. And then we're going to look to 2 partners who have deep experience related to family planning. Sylvia from PS Kenya and Chris from DKT International and CareFem. And then we're going to open it up to a panel discussion. I will note that we have 2 Q&As, as you see bolded on this slide. After the Halcyon and OFID presentation, we will take some time to take some Q&A specific to those findings. And then we'll open up to all the presenters and additional people that you see listed here in a panel in the last half hour. I do want to encourage people, and I know you've all done this more than a few times over the last 2 years, to use the Q&A and chat features to keep the conversation going. So don't feel that you have to wait. We will be monitoring the Q&A for questions that go there so that we can bring those into the conversation. So that's the run of show for today. And unless there are any burning or yearning questions, I am delighted to turn it over to Kate Siegel, who's a program manager at AVAC and has really been guiding the Dual Prevention Pill Consortium over the last several years to provide a quick readout from the consultation that we did a few months ago.
Thank you so much, Mitchell, and hi, everyone. Thank you so much for joining. I'm really excited to have this conversation with all of you today about the dual prevention pill and really trying to learn from the family planning field to inform introduction of future multi-purpose prevention technologies. So some of you may be familiar with the information on this slide, but just as a refresher, and maybe for some of you who are seeing this for the first time, the DPP or dual prevention pill is a daily pill for both HIV prevention and pregnancy prevention. There are a couple of DPPs that are in development. The one that is likely to be first to market is being developed by Viatris, and it is a co-formulated tablet with a 28-day regimen. So it combines TDF-FTC or oral PrEP with levonorgestrel and ethinyl estradiol or combined oral contraception into one tablet. As you'll see on the right-hand side, there will be different colored pills for the first 21 days, which contain the combined formulation, from the last 7 days, which contain oral PrEP only. And this was validated with women as they preferred a differentiation between the two different types of pills within the regimen. Packaging for the DPP will be a wallet pack like you see in figure 2 on the bottom right-hand side. It's meant to more closely mimic oral contraceptive packs as opposed to pill bottles that oral PrEP users might be familiar with. And the sheets will be able to be torn off by week, and they will have instructions printed on them. Of note, the pill colors, the packaging, and brand names have been validated with end users. And the branding and secondary packaging of the DPP will also have a women's lifestyle feel. Which was preferred by end users. And then longer term of note, Population Council and Medicines 360 have embarked on a partnership to develop a DPP with FTAF and combined oral contraception. So very exciting to see these products move forward, and we're really looking forward to your thoughts, questions, and insights today. Viatris plans to file for regulatory approval with the US FDA in early 2024. So we are just a couple of years off from potentially the next MPT to market. Okay, great. And just quickly, as Mitchell mentioned, we had an initial consultation with FP and SRH stakeholders in April about the DPP, and really with the objective of trying to understand what FP SRH stakeholders want to know about the DPP, what were their questions, concerns, and where potential, where excitement might lie, where the benefits might be. So we heard a few things. The first question is, will there be sufficient demand for the DPP? So we recognize that the DPP is a niche product, and demand is expected to be amongst a subset of women who desire both family planning and HIV prevention. Kenya, South Africa, and Zimbabwe will be prioritized for early introduction of the DPP, and this is due to overlapping high HIV incidence, as well as unmet need for family planning, enabling environments, including scaled up oral PrEP programs, and moderate to high oral contraceptive use. But there is potential to expand to other countries, particularly with higher OC use. So, the United States, countries in West Africa are other opportunities for potential DPP introduction later on. The second question we've heard is, could the DPP jeopardize progress on LARCs? So the DPP will be offered as one option amid a range of FP and HIV prevention options in the context of informed choice. This recognizes that women will have different prevention needs and preferences over the life course, and some may at certain points want to try or switch to the DPP. Implementation studies will be very important for really understanding, optimal counseling around informed choice, including the DPP in that conversation. And lastly, will DPP counseling confuse providers and potentially negatively impact family planning programs? So the DPP consortium, which is working to bring the product to market, it's looking at aligning counseling and delivery with OC practice to the extent possible. And this really underscores a need to expand delivery of oral PrEP now in FP spaces. So this could be through HIV and FP integration, but it could also be through task shifting, multi-month dispensing, HIV self-testing, delivery in the private sector, which we will talk about today, as well as other models and channels where family planning and particularly oral contraception is already being delivered. This will help, really prime the field to be able to offer the DPP and mitigate concerns around, confusion for providers or for users and potential negative impacts on programs. So with that, I am going to turn it over to my colleagues at Halcyon and OFID to take us through a really exciting presentation of their findings on private sector opportunities for the DPP. As Mitchell said, please do put your questions in the chat. We have time for Q&A after Rob and Karen present, and they will also be joining us for the panel. So we will get to as many of your questions as possible. Rob and Karen, over to you, and I will share my screen.
Hi, everybody. I'm currently in Senegal, and I'm not on the greatest of connections, it seems. So I think in terms of the connectivity, I won't share my video, but sorry about that. But good to meet everybody. I'm the Consumer Director of Halcyon. We're a broadcasting headquarters in Kenya, and we landscaping of the private sector opportunities for the DPP in Kenya, South Africa, and Zimbabwe. The slides that we'll present in a moment are taken from a more detailed, comprehensive landscaping report, which can be found on the DPP page of the PrEP Watch website. And in Zimbabwe, we had the pleasure of partnering with OFID, and I'm pleased that today Karen Webb from OFID joins me to present our findings. So Karen, if you'd like to just quickly introduce yourself, and then we can get going on this. Thank you.
Thanks, Rob, and thanks to AVAC and the entire DPP consortium. Good afternoon, good morning, good evening. My name's Karen Webb, as Rob said. I'm part of the Organization for Public Health Interventions and Development, and we're a local organization based in Harare, Zimbabwe. And with support through USAID, through PEPFAR, we implement a large-scale HIV care and treatment program in both facilities and communities, and also partnering with private sector partners to deliver HIV care and treatment. So this is a really exciting forum, and we look forward to sharing our findings. Thanks. Go ahead, Rob.
Thank you. So if we can get to the next slide, please, Kate. So in terms of introduction and a bit of context, our landscaping builds on and adds to previous assessments that were carried out, looking at the DPP rollout and the private sector and also the public sector. The initial service delivery strategy in 2020 recommended the DPP rollout in the first phase focused on the public sector. And private sector channels were recommended for subsequent rollout in phases 2 and 3, which would start in 2025, 26 and beyond. Now, building on this, the work that we carried out earlier this year has essentially updated previous landscaping. A lot of the analysis since 2020 on the private sector has been largely fragmented. It's been in need of updating through in-country data collection and analysis. Also in previous scopings that took place, Zimbabwe didn't necessarily feature, whereas it does in the landscaping we carried out. We've also seen, obviously, since COVID-19 and because of COVID, we've seen a growth in self-care and emerging new technologies, presenting new opportunities for private sector channels. So here, really, we're thinking about pharmacies, telemedicine, e-pharmacies, direct-to-consumer channels. And since 2020, we've seen quite an important number of new pilot studies on PrEP and the private sector which are underway. And these can, we hope, inform the delivery of the DPP through channels like pharmacies and e-pharmacies, much more than was earlier anticipated. So if we go to the next slide, please. And over to Karen.
Thanks, Rob. I'll turn on my camera while I'm presenting. So, as Rob said, this landscaping has been ongoing for a long time, and we've all been talking about PPPs for many, many decades, I think, in terms of HIV care and treatment, and also family planning and reproductive health. So it's been a really great opportunity to really deep dive into this. And so the methods that we used for the current assessment were to do a comprehensive desk review of available literature and data. So really compiling everything that we know or has been published on both the DPP and private and public sector opportunities. We worked with in-country teams in Kenya, South Africa, and Zimbabwe to really explore the different modalities of private sector opportunities, which include telehealth, telemedicine, pharmacies, and Rob will go into more detail on those. We conducted 85 key informant interviews with a very eager and willing group of key informants in each country, which range from academic to private sector stakeholders, donors, and implementing partners. So like any exercise of this nature, it comes with limitations and caveats. And one of those, which I think we'll all share with regards to the private sector, is the limited availability of data, which we'll get into a bit more. Also, the reluctance and kind of hesitation between public and private sector in many settings in terms of sharing information, the lack of available data on newly expanding channels in particular, such as e-pharmacies and telehealth, and then the non-availability of some key stakeholders at the time of the assessment. Next slide. So as 5 key themes in terms of the headlines of what we'll detail in the course of this presentation with regards to what we found with in terms of the DPP's private sector potential. In terms of financing, there's not much data available in terms of financing to guide what it should cost, how it should cost, the financing models. The stakeholders concerned may be concerned about prohibitive costs in the private sector, particularly in terms of equity issues. Prices can be highly variable, for example, in terms of oral contraceptives, which can be free or very cost effective, whereas oral PrEP can be very expensive in the private sector. Payments for HIV services in the private sector often go through national insurance schemes, whereas in the public sector, they are free or at very minimal cost in settings. And then in terms of policy and regulations, there are restrictions on PrEP and oral contraceptives, which vary in regulatory authorities. They can be they can be not implemented by lay cadres, for example, as recommended by WHO in some settings. Policies and regulations might not be in place, as said previously, for newer channels. And then in terms of coordination, it's a question of who, what, when, and how in terms of public and private coordination can be highly variable. Private sector is not intentionally invited to participate often in the public sector health coordination mechanisms. And then in terms of monitoring and evaluation, obviously, there's a need for coordination and oversight by national governments on health sector data, but there's limited availability, lack of centralization, and lack of reporting often in the private sector. And then in terms of sustainability, subsidies we know are going to be required to increase access to those who need it among key and vulnerable populations for the DPP, particularly in the short term and price sensitive markets, such as those in South Africa, Kenya, and Zimbabwe. Thanks. Rob, over to you.
Thank you. So on to the next slide, please. Thank you. So to prioritize the private sector channels, we developed a series of criteria which included considerations related to issues you can see in the box on the bottom left of the slide. So aspects such as policy, regulations, supply chain, feasibility, and others. And against these, we assessed the evidence and findings from our landscaping and ranked each of the private sector channels for the DPP in the 3 countries and gave each one a red, an amber, or a green rating. Now, in summary, across all the 3 countries, pharmacies from our analysis and our findings should be prioritized for the DPP rollout. Networked private providers also have important potential in all 3 countries, and this includes for-profit networks, social franchise networks, as well as NGOs and FBOs, particularly here in Kenya and Zimbabwe. And e-pharmacies, telehealth and telemedicine are important and increasingly important considerations for the rollout of the DPP in Kenya and South Africa. If we go to the next slide, please, Kate. So in Kenya, pharmacies are the top priority private sector channel, followed by e-pharmacies. Now, pharmacies in Kenya, they are the entry point for healthcare for the majority of the population, including the poorest. And there's more than 6,500 registered pharmacies nationally, nationwide, providing a range of relevant services and products, including OCs, ECs, HIV self-test kits, PEP, and PrEP to some extent. Some networks which are supported are piloting different ways of providing services. An example is MyShumeds, which enables clients to access subsidized family planning products and presents good opportunities to build PrEP integration within these kind of models. And what we've also seen is that increasingly the relationship between the pharmacy networks and the government is strong and increasingly strong. And we've seen the government in Kenya be increasingly supportive of PrEP delivery through pharmacy models. There's quite a few pilot studies taking place, a couple supported by the Bill and Melinda Gates Foundation, implemented by JPIGO, which are really looking at optimizing delivery models through pharmacies for PrEP. And some of these early findings and results we hope will be available sometime in 2023, providing important evidence for further strategizing on the delivery and the rollout. We've also seen an integration in the ecosystem in Kenya where the channels are not just operating, of course, independently and in silos. Pharmacies, for example, are increasingly working with telehealth channels, which are referring clients to pharmacies to get a physical product. We're also seeing the use of apps, WhatsApp chat services, online platforms, essentially, for clients to be able to also access HIV self-test kits, which can then be used at home. So we're seeing a real integration between the channels as well. Looking to e-pharmacies, this is really a very large and increasingly important growing channel in Kenya, providing a lot of SRHR and HIV services and commodities across the country, 24/7, really creating a whole new space for access. There are challenges regarding the size of sort of the e-pharmacies at the moment. This is still a sort of a gap within the data in some ways, but it is certainly an increasing channel. Selective e-pharmacies are distributing, again, a range of family planning and HIV prevention products, providing a very important leverage point for the DPP. And similarly, there's some really interesting studies going on here, also being led by JPIGO, and now looking within the e-pharmacy space, looking to really optimize a virtual care model through e-pharmacies for the delivery of PrEP. And again, we expect that some of these initial results will be available in 2023. Next slide, please, Kate. So still with Kenya, the third and fourth recommended channels are networked private providers and telehealth. So network private providers, we're here really looking at franchise networks for profit providers, NGOs and FBOs. Social franchises, obviously critically important. There's more than 600 in the country. FBO networks, also a very important channel to particularly reach rural areas and the rural poor as one of the first delivery points. Both have strong relationships with the Ministry of Health. We're also seeing growing networks of new, slightly more innovative private provider models, and also new investments from private investments coming in to support more innovative private channel delivery through clinics. And again, we're seeing integrations here with telehealth and telemedicine with the private provider networks in Kenya, making those referrals and linking up supply with demand with supply. And the fourth delivery channel, telehealth, the fourth priority for Kenya. So again, similar to e-pharmacies, we've seen a proliferation of this channel. In 2020, there were 10 telehealth companies working in Kenya. There's now about 40. So in the last 2 years, we've seen it grow exponentially. Currently in Kenya, most of these platforms, telehealth, are not dispensing, but they provide a really key entry point for service provision and referrals to a physical pharmacy or a physical clinic. We're also seeing higher demand from our analysis for FP, STI, and HIV services, particularly at weekends through telehealth. Again, really important sort of demand-driven insights coming out. And we're also seeing a very large growth in apps, which can support both the users and providers to make better decisions and generally support better quality service delivery. Next slide, please. Okay. So in South Africa, our analysis shows that pharmacies have the highest potential currently for the rollout of the DPP, followed by telemedicine and private network private providers. So with pharmacies, similar to Kenya, we have more than 4,700 registered pharmacies nationally. Important opportunities with PMARTs, which is the pharmacist initiating management of ART. This really is offers the potential for pharmacies to be rolling out ART as opposed to just medical doctors only. So a lot of decentralized self-care of greater decentralized demedicalized processes. And then also a new revised and expanded FP scope of practice, which allows pharmacy initiation of PrEP and OCs, obviously providing initial significant opportunities for the DPP. Online training for pharmacists, we've already seen more than 1,000 pharmacists trained and initiating PrEP in South Africa. With telemedicine, again, very large platform, growing significantly, similar to Kenya. The only distinction with South Africa is that in some cases, we're actually seeing telemedicine businesses actually integrated with clinical service delivery or with labs to shorten the actual delivery time, so bringing access closer to end users. And with network private providers, similarly to Kenya again, 3,000 countrywide, some really interesting models like the GP Care Cell, which is really linking private GPs and national health insurance for HIV services, and also examples like the Southern Africa Clinicians Society, which is providing ART services already to almost 350,000 patients across the country as well. Thank you, and over to Karen for Zimbabwe.
Thanks, Rob. So I'm really grateful, just to say first off, to everybody that contributed to the Zimbabwe scoping exercise. And I can see many of you are on the call, and we look forward to your comments and questions afterwards. But basically the three key channels, and so what we're looking at in Zimbabwe is likely to remain in phase 2, which is between 2025 and 2026 kind of phase of rollout of the DPP, with pharmacies in particular showing the highest potential for a public-private partnership in the DPP rollout. So in terms of pharmacies, there are over 900 pharmacies countrywide. These are highly decentralized in both urban and rural areas. So they really provide a great opportunity for achieving coverage and equity. In particular, oral contraceptives provided and was mentioned by a lot of our key stakeholders as providing a really great case study in terms of decentralization and public-private partnerships into the private sector pharmacies, where there's no prescription required for oral contraceptives in Zimbabwe. There's a Community Pharmacies Association, which is engaging with the Ministry of Health and Child Care on attempting to task shift for PrEP into private pharmacies. And this is an ongoing process and has been successful in some contexts through implementing partners and with donor support. And it's really looking to expand that and further decentralize and increase access. In terms of networked private providers, there's a really wide geographical reach with a focus on low income, high density urban areas and rural areas. Private network providers provide integrated family planning and HIV services, which is obviously a really big bonus and a huge opportunity for distribution of the DPP. Models specifically linked to reaching key populations, such as sex workers and other key populations in Zimbabwe, provide really good case studies in terms of how to work with community health workers and peer navigators for decentralizing and accessing through the private sector. And this includes New Start centers and SESHR's work with sex workers in Zimbabwe. And then in terms of public-private partnership models, there's a lot of work going on in this area, a lot of really exciting work. And what's really great and exciting about Zimbabwe is that there's a high level political commitment through the Ministry of Health and Child Care and other government bodies in terms of both the DPP consortium, which is led by the Ministry of Health and Child Care in Zimbabwe, but also in other forums, including a technical working group for public-private partnerships, and also a framework for leading the next kind of 5 years in terms of mapping the way and providing a regulatory oversight for public-private partnerships. So PPPs are a strategic objective also for donors, including USAID and PEPFAR, including OFID's Target, Accelerate, and Sustain for Quality Care for HIV epidemic control. Is really seen that these types of partnerships are going to really form a linchpin in terms of ensuring equity and continuity of HIV care and treatment in Zimbabwe and elsewhere in the region, especially in cross-border areas. There's pilot projects for art that can generate lessons for us. There's OFCAD models, out of community facility art distribution, differentiated service delivery provides a really great case study for us in terms of how to decentralize and engage with private partners for the DPP. And then, of course, demedicalization. This was a big lesson for us in terms of PrEP rollout and understanding how to roll out also oral contraceptives in Zimbabwe. Distribution of Ministry of Health and Child Care commodities through private sector through oral contraceptives was really successful and can be used as a roadmap for the DPP in Zimbabwe. Thanks. Over to you, Rob.
Rob, you're on mute if you are speaking.
Apologies. Can you hear me now? I didn't realize I was on mute.
Yes, perfect.
Okay, sorry about that. So in terms of recommendations, our landscaping makes several across each channel and across countries. The pharmacy networks, it's as in the findings as we saw, it's critical for pharmacy networks to increase their interest in the DPP, and also to make sure they're part of national PrEP dialogue and planning processes, and of course processes similar for the rollout of the DPP. In South Africa specifically, it's really important support needed to advocate for the reinstatement of PMART. This is currently on hold due to a pending court case. And it's obviously absolutely critical for us to enable a greater role for the pharmacies, both in terms of providing PrEP and hopefully teeing that up for future delivery of the DPP. For e-pharmacies in Kenya, similarly, we have the e-health bill, which is currently, it's a very progressive bill. There's an opportunity for advocacy to help this become law. And this, if it became law, would actually enable a lot of the gains that e-pharmacies have been able to make over recent years, particularly through COVID, to become, well, essentially not to be lost. They would become part of law, part of regulations, enabling greater opportunities for that particular important channel. For network providers in all countries, again, we need to increase the interest. We need to think about some of the provider bias that we've seen in some instances. Private providers in some countries have felt quite neglected through the rollout of PrEP, which they saw as a public sector priority. And in Kenya and South Africa, we recommend that advocacy supports the inclusion of PrEP and DPP in national health insurance schemes. And with some of the models that are taking place in South Africa, particularly, there's some good opportunities here. With telehealth in Kenya, again, the e-health bill is key, and really, again, just being able to bring in the telehealth sector, given its increasing size and role, bringing that into the system, into the ecosystem, working with the public sector, the Ministry of Health. Let me just finish off with the DPP models in Zimbabwe. I think, as Karen mentioned, there's a lot that we need to be learning from these models. And our recommendation at this stage is follow those, and essentially whichever models are showing promise, consider scaling up and looking at the integration of FP and PrEP delivery through those models as well. Onto our final slide for some conclusions. So to bring this all in under wraps, so I think it's fair to say our landscaping's provided a greater and more, has identified and shown that really we think that there's greater and more immediate opportunities for private sector channels to deliver the DPP than was found in 2020. Again, 2020 really focused much more on the delivery through the public sector. Now, this in part is due to some of the advances in the models and technologies that Karen and I have gone through, as well as some of the policies and practices, some of the pilot models and research. So this is really a sort of, in many ways, the ground is very fertile in many countries for a lot of private sector delivery of DPP. What this really means is that channels that were proposed for phase 2, there might be possibilities to bring that forward into phase 1. We need to think, though, about there are still some issues to really clear up and think more about, including willingness to pay, pricing models, end user validation of some of these recommended channels from our analysis. Still needs to take place in the 3 countries. However, by the end of 2022, through a private sector delivery strategy, which is under development, many of these questions or some of these gaps and further analysis of the recommendations will take place, and I hope that will be something that can be presented in the coming months as well. So, Karen, over to you for the last few points, just to stimulate some of our discussions, and then we'll close. Thank you.
Great, thanks, Rob. I can see some questions in the chat already, which is wonderful and exciting. But we really wanted to pose some of these questions back to you all, because obviously we all have a vested interest in the DPP, in HIV, and family planning commodities, and ensuring equity of access of these commodities. So some of the questions that we had are for you all are about the models or channels that you see as having the most promise for the DPP, what recommendations you might suggest for prioritization, both in your country context and perhaps on a larger regional or global level. What recommendations would you add or deprioritize that we presented to you today based on your knowledge of what's happening in the countries that you operate? Are there different stakeholders that you would recommend engaging that may have not been discussed today? And then also, what areas do you see as requiring future research? So I can see some of the Q&A questions. I won't venture into the one about from Timothy about socially marketed OCs in Kenya, but I think Robert's question about the DPP being limited to risk groups, I would like to tackle, because it's as maybe as a first pass, and then I'll hand over to everyone else. But I you know, one thing that came out really clearly from the Zimbabwe exercise is we need to learn from some of the mistakes that we made with PrEP. When we first introduced PrEP, it was really targeted towards key populations, specifically sex workers, and that led to a lot of stigmatization. To the point where now PrEP uptake and creating demand for PrEP, it also has a stigmatization, particularly among young women, who we might also envision as a key target group for the DPP. So I think, you know, we need to fold in and learn from these things, and you know, put them into our strategies in terms of accessing and marketing the DPP. So I think that's something that I just wanted to put out. But what another question, or maybe a comment, is the complexities of forecasting demand. So what happened also with PrEP, which we might envision is happening with the DPP and was raised by some of our stakeholders, is that we generated demand, but we didn't have an ability to accurately forecast how much that demand would be, and ensure that the commodity chains are really tight, and to ensure that when young women and women ask for the DPP, that it's available for them. So I'll hand over to anybody else who might have comments on this, or Rob, if you wanted to take any of the other questions.
Karen, if you don't mind, I'd actually love to jump in just in the interest of time, and because I actually think we have phenomenal questions in the chat, and some of which I think might be better suited to the panel discussion, especially once you see some of the other presentations that are forthcoming. So I did just want to quickly call on Tadesse. You've patiently had your hand raised, so feel free to come off mute and ask your question if you would like to.
Hello, good afternoon. This is speaking. Thank you for this great news.
Tadesse, it's a little difficult to hear you. If you'd prefer to type your question. Would you mind typing your question? It's a little difficult to hear you. We will be sure to get to it. And thank you so much for being so patient with your hand raised. I will just quickly jump to one other comment Khadija added. Khadija said, advocate for PMARC consolidation and expansion in South Africa versus private doctors taking legal action against prescription standards for pharmacists. Karen or Rob, I don't know if you'd like to add anything on PMARC specifically in response.
Just to quickly say, yes, absolutely agreed with that. I mean, that's one of our clear recommendations, and obviously one of the key opportunities in South Africa right now that's been held back because of this court case, with private doctors taking legal action, as Khadija says. So no, just to say that this is, we're in full agreement about that particular point, and it's, it's one of our sort of top recommendations for South Africa to really provide that necessary support. So yeah, we're on the same page there. Thank you.
Thanks so much, Rob. So many great questions. We will get to these either in the chat or in the forthcoming panel, but we do have a couple of really exciting presentations that I think will really add to the discussion. So if I may, I will turn it over to Sylvia Wamuhu from PS Kenya, who we will be presenting a really rich insights on lessons from family planning introduction in the private sector in Kenya. So Sylvia, over to you.
Thank you, Kate. So good morning, good afternoon, good evening. My name is Sylvia Wamuhu from PS Kenya. PS Kenya is a local health NGO, and I'll be taking you through the lessons we have learned at country level, and specifically the best practices for family planning introduction in the private sector. So PS Kenya has been implementing FP using two main models. The first one is social marketing, where we sell and distribute our products through pharmacies. And the second one, still under social marketing, is through the general trade. And you realize that when it comes to OCs, when it comes to injectables, we can only sell them through pharmacies because they're ethical products. The other model is the social franchising, where we manage a franchise of over 400 private health clinics. And what we do with them is to build their capacity to offer quality health services to the people that they give services, and also to ensure that they have family planning commodities that are accessible to the people who visit their facilities. Next. Next. So I'm going to embed this presentation based on the 4 Ps because we're talking about a new product, and definitely we'll need to do a lot of marketing. So just borrowing from marketing and what we need to do, I'll start with the product. Please, Kate, go back to product. Go back to product, the previous slide. Yes. So when you're thinking about the product, you have to think about all the components. There's the brand name, there's a package, the packaging, there's the quality, and also the ease to use. So I'll just give our experience based on what we have experienced as PS Kenya. And just to mention, we have family planning products, that is the OCs, we have injectables. We have tried to create a variety of the brands so that we can just serve the many audiences that are there, or the target population that we try to target. So under the brand name, we realize that it is extremely important for the name to be funky, and also to aim to kill any potential stigma that might be around the product. Remember, for example, when you're talking about OroPrep or the DPP, there is the OroPrep component, there's HIV component. So you don't want someone to feel that when they're buying the product, they need to hide the packaging. They need to feel very confident about the packaging, about the brand name, so that they can ask about it very confidently, whether they're buying from the pharmacy or even when they go to the clinic. So that is one thing. Brand name is critical. It needs to be just like any other product. And we know that in the supermarkets, some kids even want to pick condoms thinking that they're chocolates. So it should be something like that. Then the packaging needs to be very attractive and convenient to enable the people who want to buy it to carry it around, either in a handbag, they can put it in a wallet comfortably, or even in the pocket. When it comes to packaging, again, you need to think about the ease, the journey. I mean, you need to think about easing the journey for repeated visits to the pharmacies or to the clinics. Remember that these clients, they're different. Some of them can afford to buy a 3-month package. Others can only afford to buy a 1 cycle pack. So what we've done with the FamiPlan pills, and those are OCs, we are given the consumers a choice. They can buy a 1 cycle pack if they can only afford for 1 month, and keep going to the pharmacy every month to pick another one. Or if they have money and they can afford it and they want convenience, there's that option of buying a 3 cycle pack. So we've made sure that we have created that convenience. The other thing which is extremely important is the quality of the product. When it comes to family planning products, remember the many things that consumers experience, especially side effects. If it is possible, and just learning from the implementation of the OroPrep that we did a while ago, the issue of side effects really came about, and there was a lot of discontinuation because they're saying they're getting headaches, they're vomiting. So if it's possible to try and address this, when you're thinking about developing the DPP, then that would really help. And of course, that comes with using reputable manufacturers and testing the product from time to time in country to ensure that the product is meeting your standards. The other thing is easy to use. That's a very important component. The instructions need to be very simple and to the point. And just giving an example of a product we used to have, it was called Femipil. And what happened was that the consumers were supposed to take the pill based on the time of the month. So some of them had high levels of hormonals, others pills had lower levels of hormonals. And therefore it was very complicated. It didn't actually pick and you had to discontinue it. The other thing is that people need to have access to instructions. It is the era of technology. So let's ensure that if there's a way we can have a video demonstrating how to use it, that would really be good. And we've done that with our HIV self-testing kit, whereby over and above the leaflet, then the consumers can go to YouTube and just look at the step-by-step of how to use the product. Next slide. Next slide, please. So as the next slide comes, I'll be talking about promotion. That is the next P. And under promotion, I've categorized that under consumers and under the provider, the healthcare providers. Let's remember that this is a new product and therefore promotion is extremely important. The consumers need to know about the product. We have to let them know where to find it. They have to understand it. And one thing to note is that, for example, for family planning products, that is the OCs and the injectables, we are not allowed to promote them through, for example, mass media. We're not supposed to promote them to the consumers because they're ethical products. And I'm imagining because the DPP has a component of OCs, that will be the case. However, we can promote the behavior, but at the same time, not mention the brand name. And you can do this at any level, anywhere, whether it is community engagement, whether it is a radio spot. Through a radio spot, you can imagine someone will be talking about the product, you have to find it, it's new, what it does, but maybe perhaps gives a whole range of the products in the market and where to find them. And again, also social media, you can also take advantage of that channel. And let's remember that this is really new and it is a major shift for consumers. And therefore we need to really market the behavior aggressively. It takes time. For us, we took time to market the various family planning products that we have in the market, but now we have the highest market share. For example, for pills, we have 88% market share, and you can imagine it's really a mature market with so many products coming into the market. Some come in and get out, but again, marketing is extremely important. We should expect myths and misconceptions around this new product. Remember that it is new, it's about a different combination, and therefore there are always myths. Even with COVID-19 vaccines, there were myths. Even with condoms, people are saying that they are laced with HIV. Even with HIV self-test kits, everything. Even for family planning, even today, you'll find people saying that the pills and injections, they can cause cancer, all those kind of things. So very important to focus on myths and misconceptions, just to assure people that it is WHO approved, and it, of course, let them understand that they expect to experience those side effects. And what we do at PS Kenya is to ensure that we have a whole course on counseling for continuation, for them to know what side effects should they expect. And if they experience them, then it's not a major thing, it is normal. The other thing is that our campaigns for DPP need on adopting the behavior should be cool so that they can kill the stigma. And of course, we know that there'll be stigma around it. I think I've had Rob mentioning that. So it shouldn't be something that they are afraid to, they're feeling like they need to hide when they're asking the product. Let it even be cool to mention it. And just looking on my right, you can see some of the campaigns we've been having through our social media channel. And it's like, for example, HIV self-test kit. Have a HIV self-test kit. You can easily get to know your status discreetly and conveniently anytime. Hashtag HIV test kit. And you can see it's like chukua selfie, take a selfie. So it's so cool. Taking a selfie is good. So actually it really talks to people and people like associating with it. Next slide. So as the slide comes, because I can see there's a lag, I'm now moving to the healthcare providers. remember I've spoken about promoting the product to the consumers. We now need to think about the intermediary, the key person who is going to ensure that the consumers access that product. And these are the pharmacies and the health facility providers. They are critical because they're the ones who will be pushing the product. And one of the things we realized when we introduced family planning, and actually let me mention, when we're shifting from the short-term to long-term methods, it took a lot of time for the healthcare providers to change their behavior, their perspective, and even to change from what they have been doing every day, giving the short-term methods. And even up to today, we have to make sure that they integrate the long-term methods into their offering. So what we did was to really conduct a lot of trainings, a lot of sensitizations to ensure that they can understand this. The other thing that we did was to ensure that we have their buy-in. You have to convince them that the product meets the quality standards, that it is approved even by their bodies. You have to onboard their bodies, the network, the health provider bodies. Then you have to take advantage of any opportunity to talk about the product, conduct CME, sponsor some relevant stakeholder forums, attend exhibitions, and let them keep understanding the product. And even, you can even go with the products to the exhibitions to sell to them. The other thing is that at the facility and the pharmacy level, you can have champions who are pushing the product, you have TOTs, you can have mentorship or mentors who can ensure that something is happening in regard to that product. But one key thing here that I need to mention is that although you cannot promote the product to the consumers, you can actually promote the product to the healthcare providers in any way. You can put a poster at the facility level, you can leave behind information leaflets, even in the family planning rooms, you can, hang something, and you can see that photo that is there. There are enough POP and IC materials for either family planning or anything else. So we can take advantage of that channel and ensure that the health providers fully understand that. And also onboarding those bodies, very, very important. And for us, we have onboarded the Nursing Council, the Clinical Council, the Kenya Medical Association, and also for the PharmTech bodies. Then the products can get stuck at the pharmacy level. And therefore, it is important for us to ask ourselves, what is the incentive for them to push our product? So is it the high profit, is it the quality, or is it more customers? Next slide. Next slide, please. So place is the third P, and this is very direct, just ensuring that we have wide availability of the product so that it can easily be accessible. And their traditional channels, the e-pharmacies have come on board, and telehealth. For PS Kenya, for the family planning products, we have 10 direct distributors just to ensure that we're effective and efficient. And of course, it follows the normal channel. They sell to wholesalers, retailers, and then the retailers sell to the consumers. However, these 10 distributors, they double up as wholesalers, and in some cases, they have retail pharmacies. But the most important thing is to ensure that you adopt a distribution chain that is going to ensure that the product is widely available. Just giving an examples of our HIV test kits that we sell through the e-pharmacy, since it is an over-the-counter, 80% move through the physical pharmacies, 20% of this move through the e-pharmacy, and that is through MyDawa and Kasha platforms. Jumia is not allowed because it's just a general e-commerce platform. And as Rob mentioned, it's becoming popular because it provides confidentiality and convenience. For FemiPlan, it is not possible, it has not been there, we have not been doing very high sales through the e-platform because it is a low value product. And again, you have to add the delivery cost. So once the consumers count that, they realize that it's better for them to just walk to the pharmacy and buy the pills. However, remember that you have wide availability. So it's not a problem. They can walk to the next pharmacy and get the pill. And again, then I emphasize the importance of wide availability. So pharmacies also have their own e-pharmacies and online platforms, and therefore the e-sales could be higher. Next slide. So we go to the price, and the price, Kenya is really a price sensitive market, and there is always competition. And depending on the target market, there might be a need to actually have a subsidy on the product. And just giving an example of the HIV test kits, we started off with a 2.5 price, whereby we're doing about 5,000 kits. Then we lowered the price to $1.5, and we saw our numbers doubling. But currently we are selling, we don't have any subsidy on it, and our sales have gone down to about 1,200 per month, but it is more sustainable. And of course, some of the people have not been able to afford, but now that it's not subsidized, we are not doing it any other way. But just to see that there's a need at the beginning to have subsidy. Then you need to consider the current price of the OCs and the oral prep, because I'm sure the consumers will be asking themselves, if I buy this combined pill, of course it is convenient, but is it affordable to me? And just to mention, the average margin today is about 33% across the pharmacies, and we always give the distributors about 15% to enable them move the product across the other levels. Next slide. This is my last slide. So regulation, this is also another thing, because it's an ethical product. It has to go through the regulation that is required in Kenya, and the Pharmacy and Poisons Board is the regulator here. Other key stakeholders include the National AIDS Council and the Division of Reproductive and Maternal Health and the healthcare provider bodies. Endorsement is needed, and it is critical. We need to sit in the technical working groups for these divisions. We need to be able to influence what we want. We need to be able to ensure that, for example, they are included in the family planning registers, and even the heads of these departments are talking about them as another method for family planning. Then definitely, and most important, is that we need a pharmacist in-house to guide on the requirements and to be the PPB contact. This is a requirement if you have to have any ethical product. The pharmacist will also need to drive the registration and ensure that all the regulations have been met, and also getting the permits for the product. Then the pharmacovigilance component, very important. This is a new product, and therefore it is important to know whether there's any feedback that is coming from the consumers. This needs to be collected in a structured manner. And so the requirement is that you need to almost like develop the process of collecting this feedback and also submit it, so that at the end of the day, you can show that you're doing something about it and you're also aware. Communication materials also need to be approved by PPB, so that they can see whether you are over communicating or you're meeting the requirements. That is it from me today, but I'll take any questions. I think we're going to do that later. Over to you, Karen. Thank you.
Thank you so much, Sylvia. Excellent presentation. So much food for thought and discussion, which we will get to in just a few minutes. But first, I would love to turn it over to Chris Purdy from DKT International and Carafem for your insights on innovations in FP service delivery in the private sector, and what's sort of the latest landscape, and then we will turn it over to a panel. So please do stay tuned, and we will get to your questions in just a few minutes. Thanks.
Thank you. And Sylvia, loved hearing your presentation about what's happening in Kenya, all the work there. And DKT, like PSI, as a social marketing organization, and we have a long history together with PSI. We focus both on family planning and HIV. Last year, globally, we sold about 100 million oral contraceptive pills and about a billion condoms. And Mitchell and the friends at AVAC wanted me just to talk a little bit about how social marketing in the private sector works with public health. And obviously Sylvia's done a fantastic job already of sort of getting into the nuts and bolts of how that engagement works in a very practical way, bringing products to markets through pharmacies. And so I want to build on that a little bit, and then maybe talk about what potentially could be possibilities, opportunities, and challenges, particularly for this product, which I should say I'm not an expert on necessarily. So I think one of the things to remember for those of you who are maybe not so familiar with how the private sector intersects with sort of generally public health in the contraceptive space is groups like DKT and PSI and others, we basically leverage the infrastructures, the incentive systems, the motivations of the private sector to bring these health products to markets. And that involves registering those products, doing all of the QA and regulatory work, importing them, warehousing them, following through on all of the supply chain delivery of those products, which can be pharmacies, but we also deliver to clinics. We deliver those products to NGOs. We often deliver those products to the public sector, both at a central level, but also at a decentralized level. And then for over-the-counter products, not non-ethical products, you can sell those products into supermarkets and mini markets and gas stations and things like that. That work requires very strong focus, as Sylvia mentioned, on pricing. Pricing models are key. You have to look at ability to pay. You have to look at margins, because everyone along the private sector supply chain needs to make a little bit of money, at least, in order to have an incentive to make those products available as widely as possible. And I think pharmacies are obviously a very logical place for this product, but I wouldn't limit it to pharmacies. I would certainly look at clinics, as well, because certainly a lot of reproductive health products, including OCs, are made available at clinics. So the pricing model is critical. I think then you need to also focus on what I would call the demand side of ensuring those products, both to consumers. So there is a lot of education of consumers, a lot of promotion of that product. How do you make it a lifestyle product rather than a medicalized product? Because if you're going direct to consumers, like with an OC product, you basically oftentimes are taking the health provider out of the picture. That is the beauty of a woman being able to walk into a pharmacy and get a package of oral contraceptive pills, which in many markets where we operate, you don't actually require a prescription to obtain those products, particularly if you're outside of urban centers. You walk in, you say, I want this product, and the pharmacist or the rural drug vendor sells it to you. So you need to have a lot of education and explanation directly to those consumers, and that requires resources and strong, well-positioned, well-placed information. And then similarly, there's a lot of training and capacity building that needs to be done to doctors, nurses, pharmacists, and any other health providers who might play a role in that counseling work, in that destigmatization work. So those are the kinds of things that I think will need to be very that are currently in play in the contraceptive space, and as we think about bringing this kind of a product into the market, those considerations will need to be taken into account. Just to put a little bit of perspective on it, so DKT, we're in about 100 countries. We sell a lot of different products, both OTC, over-the-counter products, as well as ethical products. And we're one of the largest procurers of contraceptive products in the world. And I think it's important to note, as this discussion or this debate takes place about what is the role of the private sector versus the public sector generally is not the place that women go to for oral contraceptive pills. They tend to go to the public sector for longer term methods. If you look at the data, the UNFPA data, what they procure, it's a very small amount of money that is spent on oral contraceptive pills. So it really is the private sector that is fundamentally the way that women access OCPs. And so if this is a product that is positioned both as an OCP and as PrEP, I think the same trajectory will be true. So what are some thoughts? I've been giving this some thought as I prepared for this conversation. That I think we need to think about. One is this point that women are accessing oral contraceptives in the private sector. So we need to meet women where they are in terms of figuring out how do we communicate on the dual benefits of the DPP. The other thing we have to consider is that women switch their OCs often. They drop out. They have concerns about side effects. In fact, that's the #1 reason that women stop using oral contraceptive pills is they have nausea, or they have headaches, or there's considerations around weight gain, or any other number of concerns. And so managing through the side effects on the OC side, and I'm not so familiar about side effects on the PrEP side, but managing through those will be really critical to ensuring continuity of use. Otherwise, you spend a lot of time and energy gaining a customer, and then if you haven't managed the side effects question effectively, you basically lose them after a couple of months. I think from the time that you have a dossier, I saw that in the beginning of the presentation that you're looking at submitting this product to FDA in late 24. Approval process in the US will take presumably a couple of years. And then once you have a dossier that is ready to be submitted in places like Kenya or South Africa, which are increasingly stringent regulatory, they're not SRA markets, but they're increasingly stringent markets in terms of the processes that they follow on registering products. You're looking at anywhere between 1, 2, 3 years to register that product, and then to get it off the ground, in any significant way, a couple of years. And it takes real resources to launch a product at scale. So these are considerations as this community thinks about how to raise money for this, resources for this, and obviously it's a fairly targeted market, a fairly niche market. So how to build those markets and how to shape those markets, I think, are all considerations that are going to need to be taken into account. So I know we don't have much time left, so I'm going to keep my comments short and open it up for questions to the panel and others. So thanks for listening.
Great, Chris. Thank you for terrific comments, and to Sylvia and Karen and Rob as well. Set the stage beautifully. Great questions. I know we're short on time. I do want to quickly bring into the panel 2 additional voices, 2 great advocates and colleagues. Ruth Akula, who is actually based in Uganda with ICW East Africa and a current AVAC fellow, and we're delighted to welcome you, Ruth. And I'm also super excited to have another great partner in Natasha Koma from Copper Rose Zambia, also a longtime AVAC partner, but also an FP 2030 youth focal point. And as we get into these questions, and I know Ruth and Natasha, you both have spent a lot of time thinking about this product and the role and this category of products of multi-purpose technologies. And I wonder, as we go into the questions, if I might ask each of you just to really quickly, so we know your voices, can really quickly just give a perspective on where you think the needs are and opportunities are, particularly for access. And obviously a number of questions came up about for whom is this product and how do we make sure we get it to the people who most need it. And I think both of you can give us great insights there. Natasha, you came on camera first, so maybe I'll kick it over to you.
Thanks, Mitchell, and good morning, good afternoon, good evening, everyone. I'll be very, very honest. When I was thinking about this and preparing for this call today, I had more questions than answers. And I was coming into this to give solutions and give insights, but I'll be very honest, I have more questions than answers. Mostly because I've gotten to learn over the last few months the politics around family planning and the politics around the private sector, mostly because the private sector is driven by profits and driven by something being able to maximize profits for them and also to provide cost and scheme viability. Whereas as advocates, we are usually thinking about providing universal health coverage and doing the most good for the most people. But my advice would be, especially for the advocates, is that we need to understand the politics around healthcare in our contexts, because that's the best way to have a solution. For example, in Zambia, healthcare is something that a lot of politicians use to show that they are doing the most for the people. So the government promoting private sector use of family planning or even multiple prevention technologies is considered as them admitting that they failed to provide the service. It's not that the case, but that's just what it seems like. So you find that we are pushing government to say private sector should be more engaged. However, for them, it always seems like they failed to provide the service, and so they are less likely to do that. So my recommendation, first of all, is understanding the context and finding out on what is happening. For example, even when you look at the private sector right now, we're in a good space in the sense that 9 out of 10 of the private insurance providers do have family planning there and do have HIV. So that's a very good opportunity already to introduce a new product. However, when you look at the general landscape, our pharmacy is really interested in having more people go to their pharmacies and them spending more time explaining a product, whereas they could sell lots of OTCs for other commodities. So yeah, I'll pause here for now, but those are just my initial thoughts.
Fantastic, Natasha. And I'll just underscore what Martha put in the chat as well. Having more questions is actually a perfect thing. I think we all have lots of questions. And what we're excited about in working with FP 2030 is building a community of problem solvers together to navigate those questions over the next couple of years. So you are spot on in raising those. Ruth, I wonder if you have some quick thoughts before I go back to some of the questions.
Yes, thank you, Michelle and Kate for organizing this meeting. I am Ruth from Uganda, and when I first got to know about the DPP, and I read a lot about it, and I was very, very interested to know more about it, and I would read through every resources related to the DPP. And unfortunately, when I came across one of the articles on DPP, when the selection was being made for countries that were selected for early introduction, and I was quite disappointed that Uganda was not included. And Uganda currently we are having high HIV incidence, and also especially among adolescent girls and young women. So I got very concerned about where did we miss the point? Why weren't we included among the prioritized countries? So I had to make research, and I got to realize that there are gaps. One of the members asked in the group on what criteria was taken for these 3 countries to be selected, and one of them was the unmet need for family planning, and also we don't have currently we don't have many PrEP outlets where DPP could be easily accessible. So I decided to furthermore prepare for it. I had to organize consultation meetings, especially with adolescent girls who are very vulnerable to HIV infection and unintended pregnancy, and also pharmacists and health workers to get their perspective to support my work in pushing also, because right now I'm also pushing for Uganda to be at least included. If you're a researcher here, I'm working with the community and different stakeholders to create opportunities for DPP introduction. And during different consultation meetings, not only with the community, but also with the Ministry of Health and Uganda AIDS Commission, who are our duty bearers in creating an enabling environment for DPP introduction. So we got to realize that there are very many loopholes, and for example, HIV and family planning integration is still low, especially at the implementation stage. So we are really trying to make sure that we strengthen the integration of family planning and PrEP services to be in particular. And recently we have we launched guidelines on GBV, SRH, and HIV prevention. We believe this will be our starting point to strengthen PrEP and family planning integration. And also we also had to look at the different distribution points for PrEP and family planning services. Someone mentioned that so the family planning commodities are accessible in private pharmacies, and that's the same thing happening in Uganda. But when we look at PrEP right now is not easily accessible in private pharmacies. So we are trying to push for that and have been engaged in different high-level discussions to include private pharmacies in the conversation as one of the key outlets for PrEP services, which could also be an opportunity for DPP access point for the community, especially adolescent girls and young women. And also we have, when I talk about the IGYW, we have DREAMS program, which is another opportunity for adolescent girls and young women to access family planning and PrEP services. So we are pushing for expansion of DREAMS program to other districts with high HIV prevalence, so that by the time the DPP comes in, every adolescent girl and young woman in Uganda is able to access it. Thank you.
Oh, Ruth, we hope that's true. I know there was a question in the chat earlier about countries, and I want to just be clear that these 3 countries where the research that Rob and Karen described took place in Kenya, Zimbabwe, and South Africa. Those are not necessarily the places where the dual pill will be first launched. It's very possible they were very early adopters with oral PrEP programs, and that was why they kind of rose to the top for these conversations. But to your point, Ruth, and to the wonderful comment from Comfort in Malawi, I'm thrilled that you're in love with DPP, and we would really hope that organizations like PSI and like DKT, as Chris said, DKT is in over 100 countries. We expect that once this product is shown to be safe and effective and is registered in countries, that social marketing organizations, governments, PEPFAR Global Fund could really bring this into any number of countries. So please don't think that this is excluding any country. It's to get an initial knowledge base, but really important. And I just saw Natasha come on, and that includes Zambia as well. No one should be left behind. But I want to make sure we get to one of the first questions that came, and great apologies if I mispronounce your name, but a colleague from MSI Reproductive Choices, Banki Deseleng, asked what may be one of the most critical questions for this immediate conversation in terms of where, how to kind of map the unmet need and the role of the private sector, and is the private sector the best way to reach that need? And I wonder, I'd love to have any of the panelists address that. And certainly the private sector isn't the only way the dual pill would find its way to market, but I wonder if anybody wants to jump in of what is that added value of private sector engagement from the panel. I'm happy to call on someone. I think, Ruth, you gave a great example that PrEP isn't it. Oh, go ahead, Rob.
I was just going to say, just very quickly, I know we're sort of low on time. I mean, I think, we typically look at markets as being fairly segmented between for products that are used by consumers who use private channels, the private market, and also the public sector. So, I mean, I think that essentially it's really just, if you think about looking at the whole market, it's really about not just pushing particular products out through one channel or through the private sector versus the public sector. It really is trying to get the product out to as many channels as possible to have the maximum reach and have increase access as much as possible. I think, though, in terms of the private sector, we're certainly looking much more at the urban markets. But I think whether it's determined by, whether the product will reach whichever socioeconomic class, will be largely dependent on the issues about pricing and subsidies, as we've heard throughout this as well. So, I mean, I think those are just a few initial quick responses to that important question. And I think it's something that, as I expect as thinking and the analysis around the DPP rollout continues, that's going to obviously be a big nut to try and crack and understand better. Thank you.
Great, thanks for that, Rob. This issue of price, I know, has come up in a couple of questions, and I'll go to you, Sylvia, in a minute. We don't know what the cost of the product is yet, but the price would likely require a subsidy if we're really going to meet the need. And I think it was a question that Nantaba asked at the bottom just recently about how do we make it accessible and affordable to people who need it. And likely this would need a subsidy. And I think Sylvia gave a great example HIV self-testing and the need for subsidy. But Sylvia, please do jump right in.
Yeah, maybe just to add on to what Rob has said, the private sector is also a key sector in health. In Kenya, about 50% of the health facilities are private, whether they are FBOs, whether they are full commercial. And just giving an example, not to repeat what Rob has said, when we look at the OCs, social marketing, what we are distributing the pharmacies, and what the government is distributing, right now we are doing about 70%, because there is the whole issue of convenience. You can get it just in your neighborhood when you need it. So it's critical, and I think it's a key channel for us to learn lessons, and in the future for us now to spread the commodity to the other channels. Thank you.
Thank you so much, Sylvia. I know we're at the top of the hour, and really thank you all for staying on for the duration of the webinar. Any final thoughts from our panelists as we continue to progress toward preparing for DPP introduction, and particularly thinking about private sector engagement, all of the rich learnings we've heard today from the family planning field. Any final thoughts from anyone on the line? Natasha, please feel free.
Well, the question about the private sector being the best just gave me something to think about. While in different countries, people have different needs. For example, in Kenya, 50% is from the private sector. In other countries, the government takes up almost 70% of the patient load. But one thing I've seen is that the patient burden in hospitals is very high, and even in primary healthcare facilities. So adoption of the private sector and adoption of self-care models of delivery of healthcare services is the way to go, because it might improve the supply chain issues. It might improve the challenges that we're facing, even with other things and other delivery of other methods. And I think it could help, although the biggest bottleneck would be the cost. But with subsidies, which we've seen even with other contraceptive methods, I think we should be able to see really, really good outcomes. And all the interventions we are thinking of definitely should be coupled with community sensitization and education about the product. Because while I think Sylvia mentioned this, every new product comes with all these myths and taboos. And so there needs to be investment in a lot of the behavioral change communication, as well as just general awareness about the product. Those are my final thoughts.
Thank you so much, Natasha. Ruth, go ahead.
From Uganda's experience, we've not really been engaging so much in HIV prevention research, and I would like to applaud Kenya, our neighbor, for always moving fast, especially when it comes to introduction of different prevention technologies. So I believe that before even we think about the private sector is to engage the community, because right now we have a pharmacy model for art distribution, but still people are still reluctant, and one of the reasons because they are not really aware of it. So according to Sylvia, marketing is very, very important. While we think of private sector, we also have to think of a strategic plan on how to market the DPP in the private sector, especially in a way that would favor also young women to be able to access this product in the private sector. And also I was also looking at other telehealth platforms, and which has not really been picked up on. I'm glad that Kenya has really picked up on that area. And so it's something that we are also going to look at, and I feel it's also another very good opportunity for access of the DPP in the future. But right now we have to start with the available prevention technologies like the PrEP, and yeah, that's all I have to say.
Thank you so much, Ruth. An excellent way to close out. And I definitely suggest you connect with Nantaba if you haven't yet, who was interested in stakeholder engagement in Uganda around the DPP specifically. So thank you so much, everyone, for joining and for this really incredible discussion. We will be collating your questions and comments, and we'll send out a meeting summary in the coming days that seeks to answer many of them. So rest assured, even if we didn't get to it in the panel, we will do our best to answer it in the meeting summary. And as always, please feel free to reach out to AVAC and FP 2030 and any of our amazing panelists with further questions. And we look forward to continuing the conversation on the DPP with all of you. I will also send out, just quickly, I'll flash on the screen, there will be a few sessions on the DPP at ICFP. So if you will be there, we encourage you to join and learn more about the DPP and MPTs. We will be sending out the slides and recording, so you'll have these links in your inbox by tomorrow. Thank you all again, and look forward to continuing the conversation. And thanks, especially big thanks to all of our panelists and presenters. Have great days, everyone.
Thank you. Bye.
Bye.